Hello, welcome to the Ohio Department of Aging's PAA Provider Oversight Memory Care Training. The agenda for the training includes a review of the current service rule as well as a review of what changes will be occurring in July to the service rule. On the next slide, I'll be going through a side-by-side comparison of both of the rules so that you can see exactly where those rule changes are taking place. If you want to pause the video now and print out a copy of the current rule, you can also print out a copy of the future rule if you want to take notes. Go ahead and do that, but I will show you how to find the updated rule that's effective in July on the next slide. Next, we'll go over what documentation or what observations you need to make to verify compliance with the memory care portion of the assisted living rule. And then we'll follow that with an expectation of what we would want to see in PIMS. So we provide examples of good documentation and bad documentation and go through each of those rule requirements and ensure that it's clear what we expect to see in PIMS. I want to direct your attention to the Department of Aging's website again and talk about the steps you can take to locate information about rule updates. Once you're on the Department of Aging's homepage, you'll select for agencies and service providers, which will open up another window. And then you'll scroll down to rules and forms over on the left side. And as you scroll down on this page, you'll be able to select from the participate in rule development. This might be helpful to share with providers who are interested in participating in rule development so that they can provide comments and feedback. But as you scroll down here, you'll be able to see that there are 3 different sections: comment periods, legislative reviews, and public hearings. So if we pull down this first one, comment periods, you'll see there's nothing here. Legislative review, there are additional drop downs. So I know this is a lot of information, but the one that we're trying to get to for purposes of this meeting is the assisted living service review. Assisted living service. And you'll see that right here. And when I click on this, it will bring us to a page that some of you may be familiar with. Let's see. It's the Register of Ohio, and it houses all of the rules as well as updates about rules going through the process. So because we have refiled the initial assisted living service rule that should be going live in July, I wanted to do a side-by-side of the rule updates so that you can see the language changes between the 2 rules. So on the right side of my screen, you will see the current rule that became effective back in January of this year. And then on this side of the screen is the rule that is going through the process right now. And to get that, you'll see the rule here, and it opens up as a PDF. And that's what we see here. I want to start off by saying that the intent of the rule, the oversight of the rule, the way that the rule is operationalized more or less hasn't changed in this new version. We did try to clean up the language to make it easier to read, but there aren't really big changes that are going to impact the work that you're already doing. We reorganized the rule, and you'll see that we call out the word basic service in the newer version of the rule that comes out in July. You don't see that here at the top in the definition section. In the new rule, we talk about the personal care rule, and we do have that in parts of the current rule, but we really just wanted to call out that personal care, the definition is under the Department of Health rule, whereas in the old rule, you'll see that it's just hands-on assistance. we call out the nursing activity. I'm sorry, we call it nursing and take out activities. And we just lumped all of the other activities that are related to nursing services into this rule here that points to the Department of Health, and we took out the rest of the information in nursing activities in the old rule. You'll see that we kept coordinating 3 meals, we kept coordinating social activities, we kept what the service doesn't include. We eliminated the medication management because this language is housed within the nursing portion of the rule that points back to the Department of Health rules here. We have information about the memory care definition. Let me see. Here we go. Means a healthcare provider engaging in activities authorized by the provider's license, certification, or registration. And that's relative because we define memory care means a service that a provider provides in compliance with paragraph D of this rule, which we go into below, to the individual that a practitioner assessed and then issued documented diagnosis of any form of dementia. So what this is saying is that somebody who is a healthcare provider who is authorized by their license, certification, or registration to diagnose an individual with any form of dementia, we just provided additional detail to ensure that anybody who's receiving the memory care service has a documented diagnosis of any form of dementia that has been given by a practitioner. Going down further, you'll see that we identify the 2 certification types, the basic and the memory care. Again, we just follow this down. I'm going to scroll down to paragraph D because the language in the basic service, there aren't any significant changes, just some minor word changes that you can review on your own. So the paragraph D talks about the basic service and the memory care service. The purpose statement on the website talks about just eliminating some of the confusion around what is expected, the provider's basic service and the memory care. We, again, just tried to clean it up to make it easier to understand. Paragraph B, you'll see a lot of strike-throughs here. Again, it doesn't change the intent that the rule states providers can deliver the service where they want within the building. So I know this can look a little confusing, but it gives them the choice that the service can be delivered in a resident unit in a memory care section of the RCF, or the provider may add a single occupancy resident unit to an existing memory care section, even if the resident unit is not next door to the existing section. Again, all this is saying is that the provider can deliver this service in a room in the facility, whether it's on a secured unit or a non-secured unit, so long as they meet the additional requirements for the memory care service in paragraph D. Paragraph C, you'll note that there's additional language. A staff member who successfully completed the training requirements in paragraph D3 of the Department of Health rule. We added this language, so this is a new requirement that has to do with anybody who is delivering the activities for the assisted living provider. They have to be trained on how to deliver the activities specifically for folks who have cognitive impairment. We felt there was value in adding that requirement because we don't want just anybody delivering the activity services. We want to ensure that they understand the disease process and understand the unique needs of this population. So there will be an additional requirement to be met once this rule becomes effective in July, that those folks receive the training outlined in that rule. Nothing else through here. And we scroll down again, just some rule cleanup to align our language. In the staff qualifications, you'll see common behavior challenges specific to dementia. We wanted to call that out because currently the rule says nothing about it being specific to dementia. And then again, just some more rule cleanup. So take your time when the rule becomes effective in July and look over it. Feel free to share this version with your staff and ensure that providers know that there is a rule change coming up. They can access it the same way that we walked through together, and know that when the rule does become effective, I will ensure that the PIMS language aligns with this new rule. We're going to jump into the documents that you're going to be reviewing, as well as the PIMS documentation expectations. So over the next several slides, first you'll see the rule and what you're going to review in verifying compliance with the rule, and then the following slide will be how you reflect that in PIMS, and we're going to go over examples of what is acceptable in PIMS and what is not acceptable. So the first rule requires that the provider have a purpose statement on their website that explains the difference between the provider's basic assisted living service and the memory care service. If the provider is only providing memory care, though, the purpose statement would just need to explain the memory care that the provider is providing. Since most of our providers are providing both basic and memory care, the purpose statement would need to reflect the difference between the both. This is a very simple, high-level statement, does not need to be lengthy, and we are asking that to verify compliance with this, you visit the website. Sometimes we've had providers need to help us navigate and where that statement is located, and that is fine, but we are asking that you simply look to see where it exists, read it, and make sure that it is clearly describing the difference between the two services. Here are the PIMS documentation expectations related to the first requirement about a purpose statement on the website. You'll see that there is an acceptable example of PIMS documentation as well as not acceptable. And what we're looking for in regards to this requirement is that your documentation clearly state that the purpose statement was viewed and it included the difference between the basic and the memory care. You see that the not acceptable example simply just states that the website was reviewed. And so we are looking for just a little bit more detail that includes that you saw the statement and that the difference was clearly visible in their purpose statement between the two services. The next requirement for memory care is that the provider designates where the memory care service is delivered within the facility or in the setting. More specifically, the rule says that the provider designates the single occupancy resident unit in paragraph C2C of this rule to be a standalone memory care unit, a memory care unit in a memory care section of the RCF, or a memory care unit in an RCF of a provider that provides only memory care. Remember also that this is going to have a rule change in July of this year. Refer back to the earlier slide regarding that specific rule change. To translate what this says, essentially is to say that the provider is designating where they're going to deliver the service within their setting. This could be within a secured unit exclusively. This could be in a general area of the facility, not in a secured unit. or it could be a combination of both. When you are verifying where the provider is delivering this service, we ask that you take a tour of that part of the building where the service is delivered, just to ensure that the provider is following what they say they are doing. If they're only delivering it in a secured unit, then you'll tour the secured area. If they're only providing it in the non-secured area, you'll tour that area. Additionally, because there are other requirements like the safe access to outdoor space or the call light response times, while you're touring the facility, you'll also be able to observe how those requirements are being met as well. So the PIMS documentation expectations for meeting the requirement around where the provider is designating that they're going to deliver the service, you'll see we have two examples to share. Essentially, we're looking to see that the documentation clearly states where the service is delivered within the setting. Again, there can be the provider can deliver the service only in a secured area, they can deliver it just in the basic area, or in a combination of both. So you'll see here that we have examples that include a provider that's delivering the memory care service only within a secured unit, and then the other example that the provider is delivering the service throughout the facility, and that they don't have a secured memory unit that they're delivering the service. And again, not acceptable would be just something that says that you've confirmed it with the provider, but not indicating where the service is delivered. The next rule requirement is that the provider provides or arranges for at least 3 therapeutic, social, or recreational activities that are listed within the Department of Health Rule 3701-16-11. And this is per day with consideration given to individuals' preferences and designed to meet the individual's needs. Again, recalling the earlier slide about the rule changes in July, there will be an additional requirement for this rule regarding the training that activity staff receive. So you will need to ensure that that is captured in part of your review after July, as well as your PIMS documentation. But for now, in terms of what you're going to look at, again, it's an activity calendar for those that are just receiving memory care service. You'll want to make sure that you verify that what is being delivered to the individuals receiving the service. Sometimes we see an activity calendar that's for the entire facility, and we want to make sure that you are looking at the activities specifically for those with memory care. And you are going to verify that 3 activities are being offered per day and that there's a variety of them. Asking how the provider is ensuring that individuals' preferences and needs are met in those activities. So that might be asking the provider if they solicit input from the individuals. Is the provider reviewing person-centered service plans to incorporate preferences and needs? Anything that you can do to verify that last part of the rule regarding individuals' preferences and needs are being met, you would then reflect that in your PIMS documentation. Sometimes it's a matter of just checking in with individuals that week to see what they would like to do. So it could be in a policy, but again, your job is to ensure that the provider is reflecting that in those activities. Expectations for documentation around activities. Again, your acceptable and unacceptable example are here. You see in the acceptable example that the activity calendar was reviewed and you verified that there are 3 per day. And then you also note that the activity coordinator is seeking input from residents regarding preferences and that staff are reviewing the care plans for preferences. So it's clear what is happening in regards to meeting the individual's needs and preferences. It's clear that it's been verified that 3 activities are occurring per day. In your unacceptable example, you'll see it's very short statement about the activity calendar was reviewed, but we have no way of knowing that all of the other requirements within this particular rule are being met. Requirement is about safe access to outdoor space, and you will approach this in one of two ways. One, you'll verify that if services are delivered in non-secured areas of the facility, that individuals have the freedom to come and go as they please without any restriction, unless it's in the person-centered service plan through an HCBS modification. But most of the reviews that you'll be doing are going to be done through a secured unit, and you'll be verifying that the outdoor space is accessible within the secured unit, and then asking yourself some of these questions. Does the resident have the freedom to access the courtyard at any time, or do they have to request permission from a staff member to either unlock the door or use a keypad? You'll want to know whether there are designated times for outdoor access. So for example, at 1 o'clock every day, the door is opened during warmer months, and folks just can come and go during that time. Maybe there's a calendar posted with that information. We've seen some providers do that, particularly in the summer, where they just leave the door open and have a staff member outside to monitor folks if they're at risk of fall or wandering. And then how does the provider consider the preferences of the individuals regarding their outdoor time? Do they, again, look at person-centered service plans to see if folks have a preference? Do they talk to family members to identify when folks like to go outside? And then how are they taking that next step to ensure that they incorporate those preferences in the day-to-day activity? For example, maybe Mrs. Smith will go outside only in the mornings when it's not raining, and then Mr. Jackson only wants to go outside in the afternoon when it's cooler out. While we know providers can't meet everybody's preferences and needs all the time, we want to know that the provider is taking majority of the preferences that align into consideration and trying to meet the needs most of the time. And if there are individuals who want to go outside of that preferred time, that they are meeting those needs as needed as they come up. Again, your PIMS documentation examples include detail around how the residents are going to obtain safe access to outdoor space. In this example, the memory care is delivered only on a secured unit, so you see the documentation reflect that folks need a key code to get out, so they are either aware of the key code or they're having to ask staff to access the outdoor space. It says that residents can go outside anytime they want, meaning there are no restrictions, but they do have to ask for permission. This is reflected in their person-centered service plan too. And the provider is aware of the residents' preferences for outdoor space. You could add detail about how they are aware of that, but it just notes that you've verified that the provider has reflected that information in their day-to-day operations, and that the provider sometimes holds activities outside during warmer months. It notes that the provider has taken into consideration that that's something that folks prefer, and it just reinforces that the provider is meeting this rule requirement. So the detail will vary depending on the way the service is delivered and how the access to the outdoor spaces is being provided, but an unacceptable response would be outdoor spaces available. It doesn't tell us how it's available for individuals, where it's available, when, things like that, so we would want to see more detail. The next rule requirement is that the provider assists each individual who makes a call through the resident call system in person in fewer than 10 minutes. There are a few things that you might review depending on how the provider has operationalized this. One of the documents you could be reviewing is a policy that is specifically for the residents that are receiving memory care that says that staff have to respond in fewer than 10 minutes. Look for that particular description that it's in fewer than 10 minutes. The audit of the call lights could be something that you look at to verify that close to 100%. We know that there are going to be some outliers to that, whether it's related to a battery running out, or there may be some other extenuating circumstance that led to like a few hours in delay. But otherwise, we would expect to see the rest of the call lights responded to in 10 minutes or less on the audit. Electronically, the provider can report out or can print a report reflecting the response times. The manual option is for providers who don't have an electronic record of this, and they would have to test the call light and manually calculate if the response time is being met. So however the provider is going to do it, you could request an audit of the call light. You could also do a call light response time yourself and press the call light and see how long it takes for a staff member to respond to the call light. In some situations where memory care service is delivered in a secured wing of the facility, we have seen that the residents aren't using the call lights at all due to the cognitive decline, cognitive impairment, and we have then taken the step of asking staff how they ensure that residents' needs are being met timely. Staff have received training on checking in with residents on an hourly basis. Residents are able to indicate through their behavior perhaps that they are in need of going to the restroom or requesting some water, or whether they're in pain. So there are other ways around meeting this call light response time that don't necessarily have to be reflected in a policy or in an audit, although we certainly recommend that you start there first and then talk to staff and talk to the aides that are delivering the service to see how they meet the needs of the individuals. So use your discretion on this and report whatever your findings are, of course, in PIMS to justify your approach and how you ensure that the provider met this requirement. In terms of documentation expectations for acceptable responses in PIMS, we are looking for what you reviewed or verified to ensure that the provider is meeting this requirement. In this example, you see that the facility has a policy stating specifically that call lights have to be responded to in 10 minutes or less. And then we also note that most of the residents who are receiving this memory care service aren't using the call lights. And for that reason, we then took the next step and asked how staff are meeting the needs of the individuals. And so we noted that in our documentation. Again, we are looking to ensure that you have evaluated whether there's a policy, whether there was an audit, and that you talk with staff and administrators to verify that they are meeting the needs of the residents in a timely manner. And in the unacceptable example, you see simple statement, call lights are answered in 10 minutes. That doesn't tell us how that was verified. It doesn't tell us what was reviewed or what's in place. So please provide the detail as to what you looked at to confirm this. Did you conduct your own audit? Did you look at a report of an audit, so that it's clear what the provider is doing to meet compliance with this rule? The next requirement is about availability, and specifically about the RNs and LPNs, and that there's a sufficient number of them on call or on site at all times. The words on call and on site are defined within the Department of Health's definitions, And in order to verify whether the provider has RN or LPN on call or on site, you would look at a staffing assignment, you would look at a policy to ensure that if there is not an RN or LPN physically in the building, that they have a RN or LPN at least on call to respond to emergencies and be available. So however the provider is ensuring this, you would need to make sure that it is in writing somewhere, and just depends on how the provider has reflected that you would put in PIMS. Reflecting this in PIMS could look like the provider had a staffing assignment calendar that you looked at. Again, it could look like a policy. In this example, it was confirmed that there was an LPN during the first 2 shifts physically in the building, but then it's also noted that because this assisted living is a category C, where they're attached to a nursing home, that there is always an RN on site at the building, and that our RN is able to provide assistance to the assisted living as appropriate. The unacceptable documentation is confirmed requirement. It does not tell us the specific staffing assignment for RNs or LPNs, and it doesn't reflect any details about that staffing assignment. The next requirement around availability is the direct care staff to resident ratios. Again, all of our providers are currently providing both the basic and the memory care, so this is the staffing requirement that will be applicable when conducting reviews to verify compliance with this rule. And again, the rule says that there must be a ratio for the memory care that is at least 20% higher than the basic service. We're excited to share on the next slide that we've developed a guide or a chart that will answer this question for you, that calculates the ratios for the basic and then gives you the answer for 20% or more for the memory care. In verifying the documents, you're going to want to look at the staffing assignments for the basic and then the staffing assignments for the memory care to verify that the ratio is meeting that 20% higher. You may want to look at staff policies. However the provider is demonstrating that they have the staffing ratios in accordance with the rule is what you're going to want to look at. So in terms of how you might determine the ratio, let's talk about that on the next slide.
This is a staffing ratio table developed to address the staffing ratio percentage increase for memory care. And you'll note here that this is simply representative of the staff totals for each shift and does not include staff to resident ratio. The next slide will go over the formula that we've created that will include a staff to resident ratio. But if you are looking for just a staff to resident ratio in your basic service, you'll note in that first column that there are numbers that are then calculated by 20% in that middle column to then tell you how many staff to resident ratio you would need to meet the requirements for the memory care. So if you have 6 staff on your first shift, for example, and you want to know how many people you need to staff on your memory care, then you would see moving across the table that there's 7.2. So like I said, let's go through the next slide with the formula that will also include the resident ratio. Now we're going to take a look at the formula that we've developed to address the problem with the staffing ratio and the 20% calculation. Like the previous slide, the ratio information here is representative for one single shift, and in this scenario, you are dealing with a staff to resident ratio number that might be different in terms of your resident totals for memory care. So the formula has been developed and is locked in this screen so that when you or a provider goes in and wants to change the numbers, you cannot manipulate the formulas. But the conversion chart, or table is what we're going to call it here, will allow you to get to what the answer is in calculating the memory care staff dependent on the amount of residents that are receiving that memory care, as well as the 20% increase from your basic. So let's run through an example here of a provider that is delivering the basic service, and they have 3 direct care staff on the first shift, and they are delivering this service to, let's say, 29 residents. But on the memory care portion of the facility, the secured memory care area, let's say that they are only delivering services currently to 7 residents. So what you see here is the total number of memory care staff for that one shift would be 0.87, and that would be for the 7 residents that are only receiving the memory care. The nice thing is that this table, again, has done the math for you, has taken into consideration what the ratio is for your basic. Knowing that there are different total resident counts, it includes that factor and represents your answer in green. So to also show you that if there are the same number of residents in both areas, we would see an increase by 20% here from the basic number 3. We kept the decimal places because we didn't want to tell the provider that they would have to round up or down, that they get to decide how they want to roll out that 0.60 for that shift. So by all means, they can round up, but they cannot round down, and so that's why we did not provide a whole number, and we want to make sure that the provider is addressing any situation where it is not a full number. So again, let's just go through another example. Let's say in a bigger facility, you might have 5 aides and nurses on second shift, and they are delivering basic service to 79 residents. But this provider has a smaller memory, secured memory wing of their facility, and right now they only have, let's say, 18 residents receiving care. So what that would mean is that they would have 1.37 staff for the memory care. The one thing I want to ensure that is clear is that if your basic service staffing ratio is representative of both the waiver residents and private pay residents, that you follow that same logic when calculating the total number of residents that are receiving memory care in this line. Versus if you have a provider that has a ratio for only individuals receiving the waiver, that you also follow that through to the memory care piece. So however you're handling the basic ratio, my guess is it's more than likely going to be a private pay waiver combination, and that you will then reflect that similarly on the memory care piece. Providers are going to be receiving this document as well. They are going to receive training on it. Feel free to use a combination of this tool, the tool on the previous screen, whatever is going to meet the need of the provider to answer the question. You may also need to work with a provider who is only reflecting staffing hours for direct care instead of total people. So make sure that the provider is prepared to answer the question about a actual ratio so that you can then move forward in answering their questions about memory care staffing ratios. On the next slide, we're going to go over PIMS documentation.
In terms of documentation expectations for this rule requirement, we would want to see what documentation you looked at to verify compliance. So in the example for acceptable documentation, you see that the staffing assignments for March were reviewed. Again, it could be a policy that you reviewed, but we just want to know what you actually looked at to confirm this met the rule requirement. Additionally, we reflected the staffing ratios for the basic service for each of the shifts, and then we reflected the staffing ratios for the memory care for each of the shifts. The final note there, memory care is delivered on secured unit only, is just an additional clarification, but feel free to add any other information that you think would be helpful. Unacceptable documentation, you see that there's not a lot of information around how it was reviewed, how the provider is implementing the staffing ratios and meeting those requirements. So we want to just see that you've taken a thorough review and look at all the information and reflect each of the shifts if that's how the provider is operationalizing it. Again, use the chart on the previous slides to verify that the staffing ratios are 20% higher. And if you need to provide technical assistance around that, just make sure that you include that in your documentation as appropriate as well. Other staffing ratio that is outlined in rule is specific to providers who are only delivering memory care. There are very few of these providers, so you are not likely to see this scenario because it only applies to providers who are delivering memory care only and are not providing the basic as well. In situations where the provider is only delivering memory care, they have two options to choose from in terms of direct care staff to resident ratios. The first one is that the provider would use a representative sample, and that means they would have to do their own research in finding a representative sample of the basic service that is being delivered in their surrounding area, and then they would calculate 20% higher than that to arrive at their staffing ratio for the memory care service. Or if they're only providing memory care, then they would not have to use the representative sample and instead would use a 1-to-10 ratio where services, or in situations where services are delivered on more than one floor, that ratio exists for each floor. So in looking at the documentation, you would want to ensure that the provider shows you where they found their representative sample. Did they research this online? How did they find that information? And look over it to ensure that it is a representative sample of similar Medicaid facilities in the area and that they calculated their 20% higher ratio for the memory care. You would also look at, if they were doing the 1-to-10 ratio, you would look at staffing assignments or policy and ensuring that the ratio is reflected on each of the floors where the memory care services are delivered. In meeting expectations for your documentation, again, you would want to reflect where the representative sample came from. So in this first example, you see it was from the Scripps gerontology report, and that the provider added 20% to get to their memory care staffing ratio. The other example is that the provider is using the 1-to-10 ratio and that they have 2 floors for memory care and they have the 1-to-10 ratio on each floor. And then unacceptable is that you've confirmed the staffing ratio. That doesn't tell us which staffing ratio the provider is following in the rule. It doesn't tell us how. So make sure that you include the details that are going to reflect that the provider is compliant, whether in policy, based on the examples that you see here. The next requirement is around certification for staff members who are delivering the memory care service, and it says that the staff member has to complete training on all of the topics that are identified in the rule. So to verify this, you could do a couple of things. You could look at each of the employee files for the employees that are delivering the service and determine that the topics are trained on within that file, or you would ask for the training content that is being delivered to the employees and ensure that each staff member signed a sheet to verify that they took the training. Documentation expectations would include that you verified that each staff member who is delivering the memory care service received the training on all of the topics. You may want to call out how many staff members you reviewed, what their roles were, and that you identify how the training was met. So the note here says that the individuals all sign the training log and includes the topics that were listed in the rule. Unacceptable documentation, staff completed training. It doesn't tell us the topics were reviewed, that you verified that all of the topics were there. It doesn't tell us any other detail. Again, what we're looking for is some information about what you looked at, how it was captured by the provider, and that you reflect that in PIMS. This concludes the Ohio Department of Aging's PAA Provider Oversight Memory Care Training. Thank you.